14-0.
Motion passes 14-0. Next is Mr. Ridley Thomas. You have
Three.
Mr. Ridley Thomas, you have two items, I believe. Item number, you want to start with item number 12? That's AB 766.
With your indulgence, I'll go out of order and do 24 first. AB 1300.
That's fine, Mr. Ridley Thomas. So we'll do 1300, and you may proceed.
Thank you, Mr. Chair and members. I rise to present AB 1300. This bill is a attempt to streamline the process by which we deal with our mentally ill population that end up in health facilities. I'd like to accept the committee amendments from the analysis, which will remove the opposition of the California Nurses Association, the Professional Firefighters, Emergency Medical Services Administrators Association of California, as well as concerns expressed by the Service Employees International Union, California. I'll be taking these amendments in the Committee on Judiciary. As we move forward in the legislative process, my office and the sponsors of this bill will be reaching out to stakeholders such as NAMI, the CSAC, and the County Behavioral Health Directors Association to settle concerns, if possible, with the proposal. Involuntary commitment laws, as many of us know, were written in 1967. When written, they did not contemplate hospitals, emergency departments providing involuntary care. Almost 50 years have passed since the Lanterman-Petrus Short Act, and now it's time to update the treatment laws to better reflect our current mental health delivery system and ensure the original intent of the Lanterman Law are adhered to statewide. California hospital emergency departments are not typically considered mental health stakeholders, but they are really a critical part of the delivery care system to more than 1 million emergency department visits annually for individuals with behavioral health diagnoses. OSHPD data validates the increased use of emergency departments between 2006 and 2011. There's been a 47% increase in the use of emergency departments by individuals with behavioral health diagnosis. For all diagnosis, just as a note, the overall increase was only 14%, so that's significantly higher. This effort is a modernization effort modeled off of delivery systems that have been improved in Los Angeles and San Diego counties. With that, Mr. Vice Chair, and committee, I will allow a couple of witnesses to testify. I would also add that we've worked very closely with Disability Rights California throughout the duration of this, that I've carried the bill, and some of the stakeholders who've been working on it a little longer than I have, as well, worked very closely with Disability Rights to make this a strong bill.
We have a motion, a second. Thank you, Mr. Ridley Thomas. Witnesses in support?
Jennifer Deno, representing California Emergency Nursing Association. We are pleased to co-sponsor this bill in strong support.
Thank you.
I think we'll do it. Yeah.
Hi, my name is Mark Federnick, and I'm a full-time practicing emergency physician. I work at an inner-city hospital, California Hospital in Los Angeles, where we treat a lot of patients in psychiatric crisis. And I'm also the president-elect of California chapter of the American College of Emergency Physicians, representing thousands of emergency physicians across the state. And we've gotten quite a bit of feedback from our membership through a survey and through dialogue. And so I feel like we really understand what's going on in this situation and what this bill proposes to do, and obviously I support it. And I want to start by just sort of painting the face of the patients that we're talking about here. We're not talking about patients with mild mental illness. We're talking about patients that are needing essentially inpatient intensive psychiatric services. So patients with frank psychosis to the degree that they're unable to handle their basic daily needs, or such severe suicidality that they need to be treated in an intense way and inpatient because their lives are in immediate danger. The biggest problem, I want to just give you a view of this through our eyes. The current system does not work. There are serious flaws. There are long delays to receiving the psychiatric support that patients need, and I'm going to go through some of those steps. One issue is that we are sort of taken out of the loop, whereas we are the ones there evaluating the patient, and yet we need to wait for external resources to come and tell us what we already know about the patient, that they need inpatient care, or alternatively, that they're perfectly stable for outpatient care. And so I can give you a couple of scenarios. One would be where a patient arrives on a 5150 put on by a police officer, which is essentially a non-clinician who may not know who truly does or does not need committal, and yet based on our evaluation, we know that they should be released and follow up with their therapist who knows them well in the morning, let's say, and yet we don't have the freedom to do that. We need to wait for some outside source, which can often take hours and occasionally days, especially for our uninsured and most vulnerable patients. And then the flip side of that situation is a patient that arrives who's in clear and obvious psychiatric crisis, florid psychosis, that we know is going to need intensive inpatient treatment. And we can start some initial medical treatment, but most of our emergency departments do not have psychiatrists present and able to handle these situations. And yet we're unable to effect the next step, which is to move them to that inpatient psychiatric facility, again, without waiting for some outside team to come and tell us what we already know. You may hear a little bit today about how some of the recent legislation has already improved this process by increasing funding for the system, but I can tell you that on the ground this has not occurred. The situation is even worse than it has been in the past, and we need to do something immediately to change the situation. Emergency physicians have the expertise and experience to determine which patients are appropriate for inpatient treatment and which patients are perfectly stable and safe to go home, and this bill would give us that ability.
Move the bill. Michael Fitzgerald. I'm the current chair for the California Hospital Association Center for Behavioral Health. I'm also executive director for El Camino Hospital Behavioral Health Services in Mountain View, California. Also a clinical nurse specialist in psychiatry with 20 years experience evaluating patients in emergency departments. The situation in the emergency departments, quote Robert Frost, home is that place where when you go there, they have to take you in from death of the hired hand, and that's really what the emergency departments have become. It's become the place of last resort for treatment, but the only resort for treatment for many of our citizens with significant mental health conditions in California. Our emergency departments are severely impacted by this. I hear it from CEOs all over the state, hospitals. What can we do about this situation? AB 1300 seeks to address this issue by empowering medical professionals in the emergency department setting to provide the assessment and the treatment necessary for this population, a responsibility they have already under their medical licensure. It empowers them to utilize that. It validates the need and the approach for treatment. It takes away none of the requirements under EMTALA for safe patient care and delivery of services. There's no changing of any of the medical ethics or anything else involved with the correct care for patients. So on behalf of the hospitals in California, respectfully request an aye vote on this measure.
Additional witnesses in support, please.
David Ford on behalf of Loma Linda University Health in support.
Fred Noteware representing Adventist Health also in support. Thank you.
Stuart Thomas on behalf of the California Medical Association in strong support.
Amber King with the Association of California Healthcare Districts also in support.
Dr. Larry Bedard, a retired emergency physician, member of the Marin Healthcare District, strongly support this bill and ask for an aye vote.
Judith Riegel with the Emergency Medical Administrators Association. We had been opposed on a very specific provision of the bill related to transport. We'd like to thank the author and the committee for addressing our concerns.
Thank you, Mr. Chair. Members, Megan Brightwell on behalf of the California Professional Firefighters would also like to thank the author for accepting the amendments.
Les Shepard representing Stanford Healthcare. We're pleased to support the bill.
Mr. Chair, member Stephanie Roberson on behalf of the California Nurses Association here to officially remove our opposition from the bill. Appreciate the work from the committee and working with Assemblymember Ridley Thomas in addressing our concerns. Thank you.
Michelle Cabrera with SEIU California. We also thank the chair and the author for removing the provisions that would strike staffing ratios for inpatient psych. We appreciate your consideration, and we currently have no position.
Mr. Chair and members, Farrah McDay-Ting from the California State Association of Counties. I'm here with a concerns position. We have several concerns about the bill that we enumerated in a letter that was admittedly very late. We apologize for that. We have been in talks with the author's office and the sponsors who've been very responsive to our concerns. We look forward to working with them as this bill moves forward. Thank you.
Good afternoon. Adrienne Shelton with the County Behavioral Health Directors Association. We also sent a letter of concern to the author's office, to the committee. The concerns are in your committee analysis as well. So we look forward to working with the sponsors and the author as this moves forward. But I just wanted to also say that CBHDA worked in collaboration with Senate Pro Tem Steinberg and Disability Rights of California in the last legislative session to make some much needed changes to LPS. And there was also companion legislation, SB 82, which provided capacity grants to counties for crisis services. So we also wanted to ensure that the committee knew about that. Thank you.
Thank you. Witnesses in opposition? Seeing none. Questions from committee members? Assemblymember Rodriguez.
Thank you, Mr. Thomas, for bringing this important bill in front of us. But I have a question, and maybe I'm a little bit confused with something. So, does this affect like a first responder if they're going out to someone's house or something? Is it kind of trying to not let them go to the ER, but to a mental health facility? Is that would address that as well, or no?
No, Mr. Rodriguez. This is really when the individual gets to the facility,
to the hospital itself,
to
the emergency room.
Okay, to the emergency room. That's what this is really about.
Okay,
and you know, it arises from a number of things. And I mean, you have examples in your county. I think you represent 2 counties where we just get overloaded,
yes,
and we run out of psych beds.
Yes,
and we got to figure out how we're going to deal with our 5150 holds and how we're going to deploy emergency and law enforcement resources efficiently. And this is a step towards modernizing the system, making it more relevant, adept, and nimble to the challenges we face today.
Okay. I think you just answered my question. Thank you.
Assemblymember Bonilla.
I apologize I wasn't here for the whole discussion, and so please let me know if it's already been discussed. But I got an opposition letter from NAMI, the family members, and their concern is around the 72-hour hold. They're opposed unless that issue is dealt with. Their concern is that they feel that because of what you just described, all the impacts, that if we start the hold when someone perhaps is taken into custody, that leaves less time for them to actually have treatment. Could you respond to this concern and as to when the clock starts on the 72 hours?
Well, yes. The reason why that provision is there, and I referenced it just as I was closing my presentation, is we work with Disability Rights California to get that proposal in. NAMI's concerns, we certainly understand and will continue to work with them. There are broad spectrum of issues that are going to be dealt with. The hold may not be one that we agree with at the present time. We have committed to NAMI, its board members, its local chapters, because they have they're really a chapter-driven organization. To see what their concerns are, how they might be assuaged, and if we can find the public policy sweet spot on their concerns. I would hope that even if we cannot agree on the 72-hour hold, and when the clock starts ticking, that there are other parts of this modernization proposal that they can embrace, because it will ultimately improve the system and quality of care, and that helps their bottom line as well.
Okay. I'll be staying off the bill today and just following the progress of those discussions. Thank you.
No problem.
I'll also just note for the record that the NAMI California letter, which was I think a 3-page letter, came yesterday. So we didn't have the time we normally would like to look at the comments and suggestions and incorporate them. But there is a portion of the analysis that deals with when should the 72-hour clock start. And this bill, should it get out of this committee, and I'm recommending that it does, will be going to Judiciary Committee.
Yep.
And I want to just encourage the author and with Judiciary Committee members and the chair and committee staff to work on that issue there to try to improve it if you see there's ways that to do so.
Certainly. We'll, of course, keep in contact with the Health Committee as well because of your jurisdiction of origin.
Thank you. Assemblymember Ridley Thomas. Additional questions? Assemblymember Lackey.
Yeah, not really a question, just to remind all the committee members that this condition is a very severe condition that first responders are faced with more often than you may imagine, and that I've had the misfortune of actually seeing somebody jump to their death because of this very, very tragic circumstance. And our decisions here may mean whether this person actually gets assistance or not, and could be survivability issues. So this is a very serious issue, and I'm very happy to see that it's being brought forward.
Thank you, Mr. Lackey.
Additional member questions or comments? See none. We have a motion and a second. The motion is due pass to judiciary, and with amendments to be taken in judiciary. And Assemblymember Ridley Thomas, would you like to close?
I think I'll take my previous comments as my.
Thank you. Madam Secretary, please call the roll.
Bonta?
Aye. Aye.
Bonta, aye. Mainshine? Aye. Mainshine, aye. Bonilla? Burke? Aye. Burke, aye. Chavez? Aye. Chavez, aye. Chu? Aye. Chu, aye. Gomez? Gonzalez? Hernandez? Lackey? Aye. Lackey, aye. Nazarian? Patterson? Patterson, aye. Ridley Thomas?
Aye.
Ridley Thomas, aye. Rodriguez? Rodriguez, aye. Santiago? Aye. Santiago, aye. Steinmarth? Thurmond? Thurmond, aye. Waldron? Waldron, aye. Wood? Wood, aye.
The bill passes 13-0.
Thank you, Mr. Chair, members of the committee. I am now presenting file item 12, AB 766, which would require the Department of Public Health to give preference for grant funding for the Public School Health Center Support Program to schools with a high percentage of students who receive free or low-cost health care coverage through the Medi-Cal program. Children from lower socioeconomic backgrounds have poor health outcomes. We all know this. These disparities are due in part to barriers in accessing health care and using primary care services. Recent expansions in insurance coverage under the Affordable Care Act and expanded Medi-Cal have improved health care coverage for this population, yet, even with the expansion, children from low-income households face significant barriers to accessing care and services. These barriers include difficulties finding providers that accept their insurance, long travel times to seek care, and often feeling unwelcome in medical practices. School-based health centers provide a healthcare delivery model that can help to address some of these barriers. School-based health centers are primary care clinics based on primary and secondary school campuses that provide comprehensive health care services, including mental and behavioral health.
Move the bill.
With that, I'll allow any witnesses in support to speak. You're indulged, Mr. Chair.
Of course. Please proceed.
Kimberly Chen on behalf of the California Pan-Ethnic Health Network and the Alliance of Boys and Men of Color Health Work Group in strong support. Thank you.
Additional witnesses in support? See none. Witnesses in opposition? See none. Any questions or comments from committee members? See none. We have a motion. We have a second. Just a clarification, Assemblymember, what is your position on the proposed committee amendments?
They suffice. We're fine with them.
Thank you. The motion is due pass as amended to appropriations. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Aye. Mainshine, aye. Bonilla? Burke? Chavez? Aye. Chavez, aye. Chu? Aye. Chu, aye. Gomez? Gonzalez? Hernandez? Aye. Hernandez, aye. Lackey? Aye. Lackey, aye. Nazarian? Patterson? Patterson, aye. Ridley Thomas? Aye. Ridley Thomas, aye. Rodriguez? Rodriguez, aye. Santiago? Aye. Santiago, aye. Steinnorth? Thurmond? Aye. Thurmond, aye. Waldron? Aye. Waldron, aye. Wood? Aye. Wood, aye.
The bill passes 13-0. Next, we're going to take up file item number 5, AB 463, Assemblymember Chu. Assemblymember Chu, please proceed when you're ready.
Good afternoon. Thank you, colleagues. I very much appreciate your consideration of AB 463 to bring more transparency to our recent skyrocketing of the cost of specialty drugs. I first want to thank the committee staff and at the outset accept their proposed amendments. I know there's been a lot of discussion about this topic. Let me first start with some facts and statistics. First of all, this bill, we're not talking about aspirin or Tylenol. We're talking about high-end specialty drugs. Drugs that cost at least $10,000 per treatment, drug prices which have been exploding under our watch today. This past year, drug price inflation has tripled, the highest inflation rate this past decade, 13%. Over the past 4 years, the median price of drugs has increased by eightfold, from $1,200 to $9,300. I think, colleagues, you're all familiar with the example of Sovaldi's hepatitis C. $1,000 per pill, $84,000 a treatment, $300 million into this year's budget as proposed by Governor Brown. That amount of money is only going to serve 3,000 patients. We have 750,000 Californians who have been diagnosed with hepatitis C. $300 million, we know, could not only backfill all of the Medicaid cuts we're talking about, it could go an awful long way toward additional appropriations, education, etc. Now, this is not just, though, about hepatitis C. 70% of the new FDA drug approvals last year are specialty drugs. We have 12 new blockbusters that are expected this year. In the next 8 years, they're expecting specialty drug spending to quadruple, from about $90 billion in 2012 to $400 billion in 2020. Now, the pricing for drugs has been very puzzling. I think you've all heard that it often costs us far less to fly patients from California to other countries than to have them treated here. Sovaldi's Hep C, for example, in the United States, $84,000. If you were to go to India or Egypt, it would cost you $900, 1% of the cost of Hep C treatment here. The cost to manufacture that drug, $150. Now, the drug industry has said that prices are high because of their research and development costs, and if that's the case, that is what this bill addresses. What this bill says and asks for, it's very simple. For high-end specialty drugs that cost more than $10,000 per treatment, we want to provide public disclosure, public transparency of the costs of research and development, manufacturing, advertising, subsidies, etc. Now, the industry has raised a number of concerns, and I'm happy that we have addressed these with the amendments. And again, I want to thank the committee staff and the chair for suggesting them. We have amendments to protect any proprietary or confidential data. We have amendments that allow drug companies to report on costs of failed drugs, of basic science research. We have an amendment that says you don't have to go all the way back into time, 20, 25 years. You only need to go back for what general accounting principles of 7 years suggest. As healthcare's costs have gone up, we have tackled healthcare costs in every other area with cost transparency. Doctors are required to report costs to Medicare. Hospitals are required to report costs to OSHPD. Health plans are required to report medical loss and profit ratios under the ACA. But we haven't done this in the area of drug costs. We need to do this for our constituents, our patients, health consumers, as well as cities, counties, and states. Today at the table, we have stakeholders who often do not agree. Here to testify in support of this bill, if I may say that, that's all right. Here in support of the bill, we have labor sitting next to business, major chambers around the state. We have consumers sitting next to health plans. We have nurses sitting next to hospitals. We have dozens of organizations from around the state, and with that, I'd like to turn it over to Beth Capel from Health Access California.
Beth Capel from Health Access California. In support of this measure, our organization has supported numerous measures to assure transparency in healthcare costs, from all payer claims databases to the medical loss ratio, which already applies to health plan, to hospital data transparency. This, from our perspective, addresses an area that remains a black box. How is it that the very high cost of some prescription drugs is arrived at? What are the components of those costs? This bill will give us information specific to individual drugs, just as today in the individual and small employer market, we get information on the reasons for rate increases specific to each individual health insurance product. Just as we do with health insurance, drug costs, which are a component of the health insurance premium, we should know what's going into them. Other countries, not just countries like India and South Africa, France, Germany, many other countries get lower prices than this country does. When we have looked at why are healthcare costs in this country higher, it comes down fundamentally to the fact that the price of everything that goes into the premium is higher. Transparency is the first step to understanding what goes into those healthcare costs, and for those reasons, we're in support of this measure.
Mr. Chair, members, Sarah Flocks from the California Labor Federation. We are also in strong support of this bill simply because the rising cost of pharmaceuticals and other healthcare services is unsustainable for workers and for their families. We negotiate health coverage for 2 million union members and their families. We have some unions where the cost of health care is $10, $12, $14 an hour per member. That means that this is $14 that is not going to workers in the form of raises or wages or other compensation. That means that every dollar we spend when drug prices go up and when other healthcare services go up and our premiums go up are dollars that are not going into workers' pockets. And same for the state. Every time the state is paying for these drugs, it's money that's not going into programs that we all care about. Other programs like healthcare services and education. And that workers are also across the state paying more for prescription drugs. There's been an increase in deductibles, in co-pays, and in co-insurance, which means even when you do have coverage, workers are still paying out of their pocket every month for the drugs they need to save their lives. And these are, for us, union workers. These are middle-class jobs that are the backbone of this state, and we are foregoing raises every year because the cost of health care is killing us, because we have to give up our raises and forego any kind of wages that we have in order to pay for health care. When we talk about income inequality and the shrinking middle class and wage stagnation, part of that is because the money is going into the pockets of pharmaceutical companies and other people in the healthcare industry making money. And so we see that pharmaceuticals is an area where we need some more transparency so we can start having this discussion. The cost of Sovaldi alone is estimated to increase the cost of benefits for employers by 0.5 percentage point. That's one drug. And there are more coming down the pipeline. So there are things that we can do. As my colleague Beth mentioned, other countries aren't paying this much for pharmaceuticals. They are doing price setting and regulations in order to ensure profits and make sure people have access to valuable drugs. This bill, although we wouldn't mind seeing it, is not about price setting and not about regulation. We would support that. But this is not it. This is purely transparency. This is purely information that legislators and the public are going to need to have this discussion because it's not going away. We're going to keep having these problems over and over again, year after year, and we need to have some data to have this discussion. And for that reason, we support this bill.
Thank you. Additional witnesses in support?
Mr. Chair, member Stephanie Roberson on behalf of the California Nurses Association, strongly in support of this bill. Information is definitely powerful. We support the sunshine that is provided in this bill, and we stand in support along with Assemblymember Chu and all the other supporters to move this bill forward. Thank you so much.
Mr. Chair and members, Nick Luizos on behalf of the California Association of Health Plans. The rapidly escalating price of drugs is impacting premiums and share of costs for our enrollees. More information is needed, as stated by the other witnesses. So we'll leave it at that. We're in very strong support of the bill. Thank you.
Good afternoon, Mr. Chair and members. Tony Rice on behalf of the Los Angeles Area Chamber of Commerce. Our more than 1,600 member employers are in strong support of this legislation. Thank you.
Mr. Chair and members, Teresa Stark on behalf of Kaiser Permanente, which in California is comprised of 35 hospitals, 421 medical office buildings, and 130,000 physicians and employees and staff that take care of over 7.5 million members. We urge your support. Thank you.
Additional witnesses in support.
With AARP in support.
My name is Emily Gatfield. I live in San Jose, California. I'm an individual here to ask you to support this because the medical costs matter to me. I pay about as much to get a 6-month supply of medication from Canada as it would cost for a 1-month supply with insurance here in the U.S. Please support this bill. It is a good start. Thank you.
Mr. Chair and members, Paul Yoder on behalf of Mayor Ed Lee and the City and County of San Francisco in support of the bill.
Mr. Chair and members, Michelle Cabrera on behalf of SEIU California and our 700,000 members who believe that transparency leads to accountability. We're in strong support. Thank you.
Mr. Chairman and members, Dolores Duran Flores with the California School Employees Association, representing 225,000 classified school employees across the state in support of this transparency bill.
Mr. Chairman and members, Dan Chick with HealthNet on behalf of our 3 million enrolled and insured, urging your support. Thank you.
Mr. Chairman, members, Julianne Broyles here on behalf of the California Association of Joint Powers Authorities. Our public risk pools provide benefits for numerous public agencies throughout the state. We think this is an important way to start holding down their costs. Ask for an aye vote.
Thank you, Mr. Chairman and members. Maureen O'Haron representing Molina Healthcare of California in strong support. We serve nearly 600,000 Medi-Cal members. Thank you.
Allison Ramey with Blue Shield of California. We thank the author for bringing this bill forward and urge your support.
Mr. Chair, members, Rand Martin on behalf of the AIDS Healthcare Foundation, the largest provider, private provider of care and treatment to people with HIV and AIDS in the world, with 16,000 patients just here in California. We've been fighting this issue for more than a decade because of the high cost of drugs for people with HIV. This bill is long overdue, and we urge your support today. Thank you.
Mr. Chair and members, Betsy Imholtz from Consumers Union, the Policy and Advocacy Division of Nonprofit Consumer Reports, in strong support of this transparency bill.
Glenn Backus for California Hepatitis Alliance and our 90 member organizations in support.
Mr. Chairman, members of the committee, Sam Rodriguez on behalf of United Food and Commercial Workers, of almost 300,000 active and retirees and dependents of our labor management trust funds, we urge you to support this bill. Thank you.
Mr. Chair and members, Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies also in support.
Maureen Higgins representing America's Health Insurance Plans and Anthem Blue Cross in support of the bill.
Fred Main on behalf of CalPACE representing the 11 programs for the all-inclusive care for the elderly in support.
Mr. Chair, members, Cesar Diaz on behalf of the State Building and Construction Trades Council, also in strong support.